In emergency situations, life or death is often determined within the first few minutes of a crisis. The medical knowledge and expertise of first responders, coupled with a reliable emergency response infrastructure, can make a critical difference when an unexpected illness, accident, or widespread disaster occurs. Medical professionals and first responders often call the first hour after a trauma occurs the golden hour, because during this brief 60-minute span, lives can be saved or lost, often to preventable causes. Injuries and medical emergencies are increasingly contributing to the burden of disease in Ethiopia and are only expected to rise due to factors such as rapid urbanization and population growth, overcrowding, motorization, and industrialization. Because of this, the Federal Ministry of Health has placed a greater emphasis on improving health sector response to accidents and disasters at the pre-hospital and health facility levels. AIHA, in response, established a twinning partnership linking Addis Ababa University School of Medicine with the University of Wisconsin-Madison. With support from PEPFAR and CDC Ethiopia, this partnership has been spearheading the development of emergency medicine in the country.
The mode by which emergency medicine has been developed in Ethiopia is a twinning partnership between the University of Wisconsin and Addis Ababa University, and it was structured purposely that way as a quote-unquote north-south relationship that was intended to be a long-term vertical and horizontal relationship between the two university systems, and developing capabilities and human capacity.
Emergency medicine is a cross-cutting field. It's not a specific discipline entitled to a specific body part, gender, or anything, but it is involving all disciplines. And emergency service is time sensitive. Therefore, unless you handle it in a timely fashion, really patients will not arrive to hospitals or definitive care area. Therefore, working and developing emergency medicine really shortens time, shortens distance. Therefore, for Ethiopia, it is a new layer of care. It's a new layer of service which is really shortening these important variables. Therefore, we believe we are creating an interface between community and hospitals. That's why we believe developing emergency medicine, which have a commonality in trauma, infectious diseases, obstetrics. So many areas are touched. Therefore, if this system develops, definitely there will be a change in many healthcare indicators in the country.
Emergency medicine is critical and important, as you know, because particularly in the developing world where there is no well-established primary health care system, the first port of entry to treat patients is usually the emergency department. And therefore, that would be where most of our critically ill patients will come, and people who have never been to the doctor before. So it's really strengthening that place means providing care for a lot of people. Places like Addis are big metropolis. 3 to 5 million people live in those cities. There is a lot of international organizations, embassies, and so on and so forth. So having a well-organized emergency medical system is therefore critical for all the obvious reasons.
In Tikur Anbessa, the partnership has led to empowerment of people in knowledge, both physicians and nurses, and also it was helping in materials. They were purchasing lots of materials for us, short-term trainings. So that had empowered the whole staff as it is, and is also currently teaching all the residents. They're enrolled in this partnership program.
Emergency medicine as a distinct medical and paraprofessional discipline has been evolving in the United States for nearly half a century. But in much of sub-Saharan Africa, it is an entirely new subspecialty. Through twinning, the Ethiopian partners have had the chance to see effective emergency medical services in action at the University of Wisconsin and other resource partner institutions. They have experienced firsthand that how an emergency room is organized is critical for optimum patient and workflow. They have seen proven training curricula being taught to medical and nursing students, first responders, and seasoned healthcare professionals. Drawing on these proven models, the partners, along with the Ministry of Health and other key stakeholders, work together to adapt them to the Ethiopian context, culture, and systems, thus ensuring the end result is locally driven, locally owned, and sustainable well into the future. As a result, Addis Ababa University has been spearheading the development of emergency medicine courses targeted to all levels of first responders. These pre-service and in-service training opportunities include a graduate-level emergency medicine residency program for doctors and an MSc in emergency critical care for nurses, as well as a number of short courses in trauma and pre-hospital care for health professionals and first responders, which are conducted at the university's Emergency Medicine Training Center, which was established through the partnership.
If you look at it in the United States, emergency medicine is one of the newer disciplines, right? So if we look at its development in the United States, it's only been in the last 50 years that emergency medicine as we know it has been around. And so in many of the places in Africa, you still do not have the approach to emergency care as we do in the States. And I think that the biggest thing that we look at is having a centralized group of well-educated and well-trained physicians that are at the core of the clinical encounter. There is a lack of centralization of how you implement emergency care. And so I think through this relationship that we've had with the faculty and the residents, I think that they have a better of understanding on how our model works in the United States, and so implementing some of those things in Addis.
So the QI approach in this partnership was different than any quality improvement effort that I've been involved in for the last 30 years. And one reason why is because of the strong relationships and the twinning culture that happened around the effort. QI tools and methods are out there. Many people are doing it. You find a problem, you study it, you make changes, you measure change, you build a system around that. And we did that, and we did that well. But the other thing that I think we brought to it was when this happens in the context of a twinning partnership, it means that when I'm in Ethiopia doing training, those folks who are in the training understand my system. They have been they know my colleagues, and they have a context, and they know that we will be there to follow up if there's need.
It was really challenging adapting training for research in the Ethiopian context because I've never done that kind of teaching in Ethiopia, so I didn't know what people knew coming into the course. So I really went back to basics. I actually remember what it was like for me when I was first learning how to do research and thought about what were the best tools that I had to be able to do that and what were some of the basics that they needed in terms of learning about how to do research. My best learning experience comes from having the learning happen in a context of a problem that I'm really interested in. So we also thought about how could we engage the learner in coming up with a research topic and really walking them through every single part of that.
For the instructors, a lot of them who were going to Africa for the first time, it was a very big sensory overload. It was difficult for them to it took about a week for them to really get their bearings about where they are and what they're doing and all the different things and people they're seeing. So we evolved to where we created a 5-day course that was a very structured course. We had dedicated students, and we had a structured curriculum that was repeatable between instructors. And we found out over the last couple of years that was actually probably the most effective. The students there felt that they really got a lot of attention, they got a lot of hands-on, one-on-one interaction with US nurses. And the instructors felt that they had a structured environment that they could work in.
Through the twinning partnership, Addis Ababa University opened the country's first emergency medicine training center, established an emergency medicine center for excellence at Tikur Anbessa, the university's main training hospital, and developed a wide range of evidence-based training programs targeting first responders to postgraduate medical professionals. Human resources trained in emergency medicine went from 0 at the onset of the partnership to 4,258 by mid-2014. A new, more interactive and personal style of mentoring was introduced. Emergency care teams were established, and the value of each team member and the important roles each one plays in the delivery of quality emergency medical services became clear to all staff. A proper triage system was implemented, significantly improving patient outcomes. These and many other positive changes that sprung out of the push to strengthen emergency medicine at Addis Ababa University soon blossomed and expanded into other tangents, such as pediatric emergency medicine and critical care.
When we first went to Ethiopia, the American idea of mentoring, where people are personally and professionally engaged with the people they're mentoring, was really foreign. It was more top-down, sort of like you went to a senior person for help, but you were very private about maybe struggles you were having. And so to be able to give people the opportunity and the skills to be able to more mentor in the personal as well as the professional development part has helped and will go a long way in terms of the continued faculty development there.
The positive change which happened in the emergency departments mainly are in human resource development. We started the program when there was no any trained emergency physician. Therefore, in this period, we developed team. We trained physicians. We trained nurses. We started from 0, but now we have many physicians who are trained.
We have shown significant changes especially in emergency activities. We have improved the service, patient service and patient care areas. We have just been a role for all other hospitals as a role model for nurses. At the same time, even the teamwork was not present before the training of emergency. So we have developed a good teamwork, a good relationship with doctors and nurses. They are just working together. So this is a good change that we have brought.
We are triaging patients more efficiently now. Critical patients are being evaluated and being managed in the emergency properly now. So the patient care, I think it has improved very significantly. Other departments, other physicians, other residents, since coming to the emergency department and being trained on emergency trainings, there have been different change in attitude of other physicians and our colleagues as well. I think that's a very significant change. We have seen how the pre-hospital care works in South Africa. So in Ethiopia, like there are some pre-hospital care providers, but it's not that much organized. And we have seen how it's organized, how it should be organized, and it was a very good experience. And we have also seen the ambulance services as well as the air ambulance services, air emergency service. So it has given us, did give us a good perspective.
A lot of changes seen within a very short period of time, like team spirit, working in team can do a lot of change, a lot of improvement in patient care. Being by the side of physician can make nurses to be autonomous, decisive for that matter, quality care, and acquiring important skills and a lot of things.
The other part to all of this, I think, is just the development of our relationship, the success of the relationship between the University of Wisconsin and Addis Ababa University. I think the nucleus around emergency medicine, or started around emergency medicine, but then quickly has spun off on tangents purposely into pediatric emergency medicine, into critical care. So there has been a tremendous amount of work that initially started around emergency medicine itself, but then quickly, went in many different directions. And I think that has created bonds and deep relationships between the two institutions that, transcends money, transcends time, and things like that. So it is, I think, a success that will hopefully be carried forward for many years to come.
I think advocating for the care of patients in the emergent setting in Ethiopia, I think that that's why we go into medicine, right? It doesn't make sense to build a training program if you're not going to have downstream effects on patients. And so I do think that through the better preparation, the better training that they're receiving, the helping to facilitate the physical plant within the emergency department, the quality improvement projects, we are seeing better patient outcomes in the department there.
International twinning partnerships are a highly effective model of technical assistance, but each one faces certain challenges, such as finding the best methods of communicating across different continents and many time zones. The Addis Ababa University, University of Wisconsin partnership also faced the added difficulty of introducing a largely unknown clinical subspecialty into the existing health system. Despite these and other challenges, the partners persevered.
Looking back, when you started the residency, there was challenges from day one. And it was challenges from all the residents, other residents. It was previously the emergency department was run by other departments jointly, so nobody knew what we were there to do. Nobody knew about us. Nobody knew what emergency medicine was. So we have to fight through all that and prove ourselves from day one and let everybody know what emergency medicine is all about.
One of the important challenges is communication. We are mostly using telephone, internet, and Skype communications. In the beginning, we were not using all of them. Therefore, distance was really a matter between we in Addis and also our partners in University of Wisconsin and also other universities. But through time, there was a discussion, planning, and also motivation to use different modalities of communication. And time was also fixed, at least to communicate every 3 months through Skype and in between through different means.
And most importantly, challenges that are difficult to sort out are, some of the conditions that are laid by overall the granting mechanism, because it's usually to a specific task and it doesn't really see across disciplines and across systems to strengthen. And so those are challenges which we have to navigate very tightly. And so we may have a very functional emergency department, but the hospital may not be up to speed.
Although partnerships are institution-based, they make a real and lasting impact on the individual health professionals on both sides. The Ethiopian partners attest to the enormous benefits of working in close collaboration with highly experienced specialists. Seeing new models of care in action and seeing firsthand the value of a multidisciplinary team approach to care. For the U.S. partners, many call the experience life-changing, saying that the fresh perspective they gained on their profession and seeing the constraints of working in a limited resource setting had resulted in a reconnection with what drove them to emergency medicine in the first place, improving patient care.
From this partnership, I have gotten so much. I think the establishment of the training center was, due to this partnership. And from day one, we have been trained by physicians coming from University of Wisconsin. So they basically help train us and they help us know what emergency medicine is and where it is in the rest of the world, specifically the developed world.
I work in emergency department and anesthesiology department. I am anesthesiologist in profession and emergency medicine fellow. I learned a lot. One, I came more capable to teach my students on emergency medicine. I came with more experience on how to organize the pre-hospital service, as well as how to organize the triage area, the resuscitation area. So it was quite new for us. Triage is quite new concept for us. There was no any triage service in this hospital, even in this country. So after having this collaboration, this exposure, I have tried to adopt the triage form from different countries, including UW. I have learned that how nurses and physicians are working in harmony, and how they are very important for the patient's management and outcome. So this we also again tried to implement.
It's been really exciting for me to engage where research and mentorship are new. I guess it's helped me really look at things from a fresh perspective, because in our culture here, I mean, research has been embedded, mentoring has been embedded for centuries, you know. And one day, the first trip, we went and saw the emergency room for the first time, and we really saw where a lot of these fellows who'd been part of our training for the last 2.5 days worked, right? Went day in and day out. So to see the reality of that was obviously an impactful moment. But to see what those young doctors gave up to attend this training really reconnected me with the power that comes from the capacity to conduct research and to develop new knowledge. We even redesigned our trainings here based on the trainings that we had developed over there, because we really did those according to best practice. Here we were still doing a lot of, well, time is short and it's hard to get people, and we're like, no, you know what, we really realized this is what works pedagogically, this is how we need to be teaching this, and we need to be doing this back with our own students as well.
It was a very, very heartwarming and eye-opening experience. I have never worked in a hospital in Africa before. I grew up in a third world country, but my entire professional career has been in the United States. So the ideas I had were only from reading and hearing and watching, but to experience that firsthand, I wouldn't be overstating it if I said this was a life-changing experience.
While the US institutions are considered the expert or resource partners, the dynamic and participatory nature of twinning almost always results in reciprocal learning. Over the 2 decades AIHA has been implementing twinning partnerships, our US partners are quick to point out that they have learned just as much as they have taught, and the Wisconsin partners are no different. Their work developing training curricula based on the latest evidence-based research in collaboration with the Addis partners resulted in the Wisconsin team revising their own curricula, for example. But above all, it is the personal connections made between like-minded colleagues and the realization that they have made real and sustainable improvements in Ethiopia's health system that have made their efforts even more worthwhile.
I think partnerships work well when there is always goals that are shared, of course, and also responsibilities are shared. That said, I think partnerships work even better when the benefits are bilateral. Overall, our relationship and partnership has, from the get-go, started with that kind of a fundamental belief. I really also think the amount of dedication and deep energy and feeling to make this work from the Ethiopian side was a crucial ingredient. It really is a situation where partners were all coming together to make this work because they all believed in the final result that we are looking at.
The UW staff, they work in well-organized areas, and the patient composition is very different, the setup is very different. I think they have learned a lot how to work in
areas with inadequate resources. I think they also can have some experience share with our students. Even though we have scarce of resources, but our students are were good, and it was sometimes above the expectation. So people may understand, oh, if something is fulfilled here also, we can serve the people on the same standard.
I think one of the most important things that we've gained is the personal connection with colleagues at Addis Ababa University. The ability to connect with various colleagues from both sides, and thinking of this as a two-way relationship, where colleagues from Addis Ababa University and other colleagues from Ethiopia could actually come to the University of Wisconsin and other institutions that are participating in this partnership and experience how we take care of patients here. But equally as important, I think, in this relationship is for our trainee to go to Addis Ababa, work at a Black Lion Hospital, and learn how physicians there can actually take care of patients with less resources.
As others have probably alluded to, there's probably just as much learning coming our way as we could ever hope to impart going their way as well. And so that has been a very rewarding part of this whole relationship as well. But the root essence of this is a twinning partnership on a university, on an institutional level, not just individuals going over, one at a time piecemeal, but an organized, higher-level institutional partnership.
Emergency medicine as a clinical subspecialty in Ethiopia is still in its infancy. The task of nurturing and growing this new discipline is enormous. It is also dependent on the political will to support the necessary development of a strong framework for ongoing development of systems, structures, policies, infrastructure, and well-trained professionals. The pioneers who have been trained through the Twinning Partnership are dedicated and enthusiastic. They have helped usher in many positive changes over the course of the partnership, some clearly evident and some that have not yet come to fruition. These emergency medicine professionals are leading the charge as they work to provide well-organized and high-quality emergency medical services to the people of Ethiopia.
They are very young, and there are a lot of enthusiastic young residents and fellows who are finishing soon, and their task is enormous. And I think surely but slowly they are also understanding the magnitude of the task they have in front of them, which basically becomes creating an emergency medical system for the entire country. So that is huge, and I really think there is a lot more to be done yet. We are talking about one school, we are talking about few doctors being trained, and it's a big country with 90+ million people. And so there is a lot of infrastructure to yet develop, and also people to train.
The collaboration should continue, because emergency medicine as a field and a discipline is very new field and infant. There is big need, everybody agrees. Both in US, Ethiopia, other African countries, everybody's question is to solve emergency problems, but how to solve is the issue.
The future can be bright, but I think that there needs to be a lot of work. There are changes that you could see within months, but there are some changes that will take decades, like it did in the growing countries, how emergency medicine evolved. So, but through time, I think better care, better pre-hospital service, which was non-existent till a couple of years back, and also better emergency centers in all the hospitals in the government as well as private hospitals, where best emergency could be practiced for the physicians as well as patients get emergency care.
And then particularly to the nursing part, I think a lot of things has to be done. I mean, making nurses autonomous, making nurses and just equipping nurses with knowledge and skill do have a lot of contribution for changing or for getting a better emergency care.
I think what emergency medicine is going to look like in Ethiopia is definitely going to depend on, of course, a lot of things, particularly what are the policymakers going to put in place to support this young specialty to grow. And just the mere presence of physicians trained in this is not going to be enough. And so I really, truly believe that this emergency care, particularly in the big cities like Addis Ababa, is a must-have, and therefore I think in the next few years the services, be it the pre-hospital service as well as the hospital service and staffing of the emergency departments and the structures around the district hospitals and regional hospitals hopefully would change. I just want to say, I mean, we had really a lot of great people who have been part of this project, and projects like this really need not only money but a lot of folks who from both ends volunteer their time, and things like this could not be done without volunteers. And I just don't want to also forget the role of the funding organization like the American International Health Alliance, who have been along the way helping with the communications and also closing the gaps and giving guidance whenever guidance was needed. And therefore, it really is a situation where partners were all coming together to make this work because they all believed in the final result that we are looking at.